It is a great honor for me to introduce our next speaker, Dr. Maya Natarajan. She has completed her MBBS from Madurai Medical College in the year of 1999. She completed Diploma in Ophthalmology from Aravind Eye Hospital, Madurai in the year of 2004. Then Fellowship of All India Collegium of Ophthalmology in Refractive Surgery in the year of 2018. She worked as lecturer in the Department of Ophthalmology at Manipal College of Medical Sciences, Nepal. Also worked as consultant ophthalmic surgeon in Pratibha Eye Hospital, Mangalore. Then she worked at Vasan Eye Care Hospital, Mangalore from 2010 to 2016 as consultant, phaco and refractive surgeon. Currently, she is the surgeon of cornea and refractive department at Jyotis Eye Care, Kannur from 2016, along with her own practice at Amrita Care in Mangalore. She also have many publications and presentations. Also, she is the assistant professor of Mangala College of Allied Health Sciences. So, I hand over the mic to you, madam.
Good afternoon, everyone. Thank you so much for those kind words of introduction. I do not envy the speaker who takes the podium just before lunch. I know all your stomachs are grumbling. There are a lot of slides, but I hope the topic is interesting and it'll keep you hooked. So today, the morning session was all about retinoscopy and refraction. We are moving now in ophthalmology to a more instrument-based practice. Most of us depend on a lot of instruments like topographers, OCTs, perimetries for our day-to-day, diagnosis. So it's very important, and most of these tests are actually done by the optometrist. Some of the interpretations in many of the hospitals are also done by optometrists. So it is very important you update yourselves on these topics as well, not just retinoscopy and refraction. You need to know more of this, especially if you want to look for opportunities abroad. You need to know and update yourselves on the technology aspect as well. So we all know that the corneal topography gives you a scan of the cornea and gives us a wealth of information about the cornea. So understanding and reading a corneal topograph is what I will be talking to you today, especially how to rule out a keratoconus. So there are many values and indices to go by, but this basically remains a pattern, and this remains exercise and pattern recognition. So for example, when you look at this map, you'll immediately know that this is a world map, and you know where the oceans are, where the seas are, where the mountains, plains are. So this is because you've been exposed to reading such maps for a very young age, and this is an exercise in pattern recognition. Similarly, the more we see, the more we know, and the more we know, the more we see in a corneal topography. So when do you actually ask for a topography? So when we suspect a keratoconus in a patient, diagnosing a keratoconus very early is one of the main advantages that corneal topography offers. You can pick up a keratoconus very early, especially with the advent of newer procedures like corneal collagen cross-linking to stop the progression of keratoconus. It is very, very important or imperative to pick up a keratoconus very early. I know scissoring reflex in retinoscopy is definitely one of the earliest and easiest ways of picking it up, but we know that keratoconus is a disease that starts from the posterior cornea. So it's sometimes in a very early or a form fruste keratoconus, it is not possible to pick up a keratoconus at that stage. So that is where a topography comes in. In specialty contact lens fitting, when you have to fit even soft contact lenses, sometimes torics, GP lenses and scleral lenses, you need to know not just the central 3 mm of the cornea, but the 7 to 8 mm of the cornea or right up to the limbus to fit the lens. So irregular corneas, when you fit with specialty contact lenses, you need a topography. In a preoperative LASIK planning, not just for predicting a postoperative ectasia, but also in treatment planning, how much of optic zone of correction to give. All these things you will need to get a topography done, and in phakic IOLs as well. When we plan cataract surgery and want to implant advanced technology IOLs like toric IOLs or multifocal IOLs, it is very important to rule out an irregular cornea or an irregular astigmatism before we take up the patient. So that again you will have to ask for a topograph. And when we plan intracorneal ring segments in a keratoconus, that is again a place for topography. So just a few words about history of topography. We all are very familiar with this instrument. It is a relic actually these days. So this is a Placido's disc where the central +2 diopter lens through which you look at the cornea. Now we know that the cornea is or the tear film basically reflects part of the incident light that is falling on the cornea. So the closer the Myers of these Myers, the steeper will be the cornea. Wider the Myers, flatter the cornea. This does not give any information on the quantity of the curvature. It only gives you a quality of the curvature. So that's where the curvature-based instruments came up. So we know the keratometer. The keratometer is seen in most of our OPDs. And the disadvantage of the keratometry is that it can measure only the central 3 millimeter of the cornea. It does not give us information about the peripheral cornea. So then came the computerized video keratoscopies. Now these project light or a lighted ring onto the cornea, and the image that is acquired will be analyzed by a video software, and that gives us information on the curvature of the cornea. This gives us information almost about 70% of the corneal surface, whereas the keratometer would probably give us only around 15% of the corneal surface. Now, with all these Placido-based instruments, you could measure only the X and the Y axis. You never knew what the elevation of a point on the cornea was. So that is where the elevation-based topography or the pentacam came in. So the Z-axis to measure the elevation at a point came in. So should we call it as a topography or a tomography? It would be ideal to call it as a tomography because it would be a 3-dimensional measurement of the cornea. So there are many methods and instruments for corneal tomography. I will not go into details, but there are 2 main methods we need to know. One is a horizontal slit scan and the other is the rotating sheen plug. The horizontal slit scan, OpScan, and the rotating sheen plug, the pentacam or the oculizer. Most of the maps that I'll be showing today will be from the oculizer by wavelight. So these are the instruments. You have the pentacam with a sheen plug camera, and the Sirius with an additional Placido disc, and you also have a Galilei with a dual sheen plug camera. Now, to understand the sheen plug principle, you need to know a little about the camera. So in a camera, you know that the object plane, the lens plane, and the image plane are parallel to each other. So when one plane is focused, the other plane is not focused. For example, now we want to image the anterior cornea, you want to image the posterior cornea, you want to look at the iris plane and also the lens. So if you focus on one, the other goes out of focus. So how do you get across this? So sheen plug was the one who proposed this. So by tilting the lens plane, he brought all the 3 into focus at a plane. So you would get a clear image of the anterior surface of the cornea, the posterior, the iris plane, and the lens. Everything comes into focus. So this is what today we are going to discuss. This is the topograph from the printout that you would normally get in your hand. So on the left, on the top, you have the patient parameters, the name of the patient, the date of birth of the patient, the eye to be examined, all that are there on the top left. And below that you have all the corneal parameters, and then you have nice 4 colorful maps. The top left map is the anterior sagittal curvature map. Then on the top right, you have the anterior elevation. Below that you have the posterior elevation, And the fourth map, this map, is the pachymetry map. Okay. So now going to the corneal parameters. What are the corneal parameters that we need to know? The first thing to know or see are the K readings. Now the K readings are given in blue and red, the blue being the flatter axis and the red being the steeper axis. And then you have something called as the Km, or the average of the Ks that are given over there. Okay, it's too small to read, but still. And the astigmatism with the axis is given below that. So these are the anterior K values. And then below that you have the posterior K values. These are again very important when it comes to diagnosing a keratoconus. Now, before that, we'll also need to first, before reading any scan, you will need to look at the quality of the scan. So if the quality of the scan says okay, then it is okay to proceed to read the scan. If it is not okay, you will have an exclamation mark over there and you will probably need to repeat the scan. Coming to the next value, the Q value. The Q value gives us the sphericity of the cornea. Now we know that the normal cornea is not a normal spherical surface. It's actually a toric ellipsoid surface. When a patient undergoes a LASIK, the central area is flattened and the cornea becomes a oblate surface, we call it, and it attains a positive Q value. Whereas in a normal cornea, it is a prolate cornea, where the center is a little steeper and the periphery is a little flat. So you have a negative Q value. That is why the normal value of this Q is from -1 to 0. In a keratoconus, you have a terrific steepening in the center. So when that happens, your Q value becomes very negative. Now coming to the pachymetry readings. Now these pachymetry readings are very important. There are 3 pachymetry readings that are given over there. The pachymetry, or the thickness of the cornea at the apex of the cornea. Apex is nothing but the anatomical center of the cornea. So that is given. So that is why the X and the Y axis are 0, because that starts from the apex only. And then you have the thinnest location of the cornea. So before that we will look at what is the pupillary center. Now you have to understand that the apex and the pupillary center don't necessarily have to be the same point. And the difference between the two is what is called as angle kappa. So angle kappa is very important, especially when planning treatments in hypermetropes and phorias. So there can be a difference between that. And then there's something called as the thinnest location of the cornea and the central 5 mm of the cornea. So all these are very important when diagnosing a keratoconus. So once you have read all, so there is a lot of information that is given here. Most of the information, if you can read from this, then you go on to reading the color maps. So there's a little bit more information given about the anterior chamber. So the anterior chamber volume, the angle, the antechamber depth, the pupil diameter, all these are also given here. And this is very important in predicting an angle closure glaucoma in patients, or when we are planning a phakic IOL and we have to put a lens inside the anterior chamber. Then again, we will have to look at all these values before going in. So pupil diameter is again very important in planning treatments, LASIK treatments. So this is the anterior sagittal curvature map. You have the anterior elevation map, you have the posterior elevation map, and you have the pachymetry map. You have 4 maps, and we'll go across this quickly. So the anterior sagittal curvature map is the most important map that is used even for contact lens fitting. Now this is a normal bow type pattern that you see here. The first thing you have to look is which eye has been examined. OS is written here. It is the left eye over here. Also nasal and temporal will be given, which side is nasal and temporal. Now the black dotted line that you see over there is the pupil. And then you have black solid lines at 3 mm, 5 mm and 7 mm of the cornea. Now along with that you have 2 lines running across, one in red and one in blue. The red one depicts the steeper axis and the blue line will depict the flatter axis. So this is basically all the information that you will get in an anterior sagittal curvature map. Now you also have to remember that there is something called these color maps, the one on the top left and the top right. they actually are the same map. But the scale that is used to color them is actually different. So on the top left, you have an absolute scale, and on the top right, you have a relative scale. Now, this is very important, especially when you compare topographies from various different topographers. You'll need to make sure that the scale is the same. Sometimes if the scale is different, both are the same actually. There's no difference. But just looking at the colors, you should not be confused. So this is a symmetric bow tie vertical. Now this is nothing but a with the rule astigmatism. What you're having is a symmetric bow tie vertical and with the rule astigmatism. This is a symmetrical bow tie. The upper lobe and the lower lobe, or the lobe on the left and the lobe on the right, are of same shape. So this is symmetric bow tie, horizontal or against the rule astigmatism. Now if it is between the two, then you would call it as an oblique astigmatism. So this is a typical oblique astigmatism. Now even though you get the values of these astigmatism in the corneal parameters, it is very important to correlate that with your manifest astigmatism. Whether this is only corneal astigmatism we are looking at, or it could even be lenticular astigmatism for that matter. So you need to correlate that. So there are many abnormal patterns in a keratoconus that you can see here. So these are the various abnormal patterns. I'll be showing some scans that you can see. So this is an abnormal cornea. You can see that the central values are close to around 57, 58, and it's showing a central steepening, a regular central steepening. So this is a round pattern. This is an inferior steepening. You can see that there are hotter colors inferiorly. So these steepened areas are usually depicted by hotter colors in the sense red and yellow, whereas the flatter colors are usually green and blue. So you can see that there is a clear-cut inferior steepening in this scan. You can also have a symmetrical bow tie. Now you have a symmetrical bow tie. The upper lobe and the lower lobe look the same. There's like no difference there. But when you draw a line through the upper lobe and through the lower lobe, you see that they're dissecting at an angle. And if this degree is more than 22 degrees, then we call it as a skewing of the radial axis. Again, this points to a keratoconus, a very early keratoconus. So this is again an asymmetric bow tie. You see that the upper lobe and the lower lobe are of different shapes. The upper lobe is smaller and the lower lobe is much bigger. This is the inferior steepening that you see here. Now this is an asymmetric bow tie. You can see that the superior lobe is smaller and the inferior lobe is bigger. But when you draw a line, there's a skewing. There's more than 22 degrees, it's almost 45 degrees, and there's a skewing of the radial axis. Now this is a horizontal bow tie, but again, there's a difference in the shapes of the lobes. So this is a nasal steepening in the right eye. Now this is an asymmetric bow tie, but with a superior steepening. Now even in a normal cornea, you have to understand that the inferior cornea is slightly steeper than the superior cornea. So at the 5 millimeter ring, if you take the values of the diopters superior and inferior, the difference should be less than 1.5 diopters. When there is a superior steepening, it should be less than 2.5 diopters. So this is an asymmetric bow tie with a superior steepening. Now there is another map which is called as the tangential curvature map, and this map also is very important because it takes the neighboring points into account when taking the map. So this detects local changes and peripheral data better than the axial map, and this especially is useful for fitting lenses. So you can see here that the cone is very nicely seen in that area, and all the other areas look flatter, and you can see that the central area is looking steep. So this is again another tangential curvature map. So we will go to the second kind of maps, which are the elevation maps, both the anterior elevation map and the posterior elevation map. So elevation is nothing but a point on the cornea is compared to a reference body which is computed by the computer itself. So any point that is above that will be given a plus value. Anything below that will be given a minus value. So now when you also have to remember that the steeper axis will be below the reference body. So it will be depicted in blue, whereas the flatter axis will be above the reference body and it will be depicted in red. So when you look at these 4 maps, you look at the axial sagittal map, you know that it is a with the rule astigmatism, right? So you have a vertical bow tie. So next to that, when you look at the anterior elevation map, you feel that the vertical area is actually flat. That's not the case. We're talking about elevation maps here. So elevation maps are different. The steeper axis will be lower. That is why it is depicted in blue color. So should not get confused between the axial maps and the elevation maps. So there are various reference bodies: spherical, toric ellipsoid, and enhanced Besphere. These are done by the computer themselves. So again, you can have the normal elevation values in the anterior map and the posterior map. So in the central 5 mm, you'll need to remember that the value should be less than 5.5 microns in the anterior elevation map. In the posterior elevation map, it has to be less than 12.5 microns. So there are many abnormal elevation maps which can tell us that there is a keratoconus. So this is how it would probably look in a keratoconus. You'll see a central island popping up over there, and the values are almost close to around 46, 33 diopters. It's not less than, this is the back elevation we are looking at. So it should be less than 12.5, but the values are much higher. So this island will tell you that there is a keratoconus over there. So again, these are small islands, a very, very small island over there. You can also have a tongue-like extension coming in like this. So the final thing is the corneal thickness map. Now we give very undue emphasis on the corneal thickness. So what is this normal corneal thickness? Like, would it be 500? Would it be 540? Would it be 450? So there are various ranges, various populations differ in their corneal thickness, but anything over 500 is considered as normal. Anything less than 470 is considered as a thin cornea. So again, I've already talked about the thickness at the apex of the cornea, the center of the cornea, and the thinnest location of the cornea. So how do we know? In a keratoconus, we know that there is a thinning of the cornea. So in a this is a keratoconic eye. This is the thickness map in a keratoconic eye. The thinnest location normally should be more than 470 microns. If it is lesser than that, you have to suspect a keratoconus. And there are many other parameters also, but the most important thing is that it is an inferior displacement of the thinnest point. So the thinnest point on the cornea will be displaced from the apex of the cornea inferiorly usually. So that is what you need to know. Again, keratoconus is a very highly asymmetric disease. So right eye and maybe one eye is absolutely normal and the other eye may show changes. So you need to compare the findings that you're seeing in the scan between the right eye and left eye, and if the difference is significant, then you'll have to take that into account while scoring or assessing a topography. So there are a few points that you need to read. So the first thing you'll need to look at in a corneal topograph is the quality of the scan. That's number 1. Number 2, you look at the maximum keratometry. If the maximum keratometry is more than 1 diopters of the steeper keratometry in the center, you have to suspect a keratoconus. Number 3 is the pachymetry or the thickness at the thinnest location of the cornea. If it is less than 470, you have to be suspicious of keratoconus. Again, the thinnest location displacement, how far it is displaced from the center, number 4, that you will have to look at. Number 5 will be the Q value. I already told you about the sphericity of the cornea. Number 6 is the anterior sagittal curvature map. 7 is the elevation, anterior elevation. 8 is the posterior elevation. 9, you will look at the pachymetry. And a few other things in the form of corneal thickness, spatial profile, and other things which are a little too in-depth. I'm not going into them. If in all this, you just remember only this slide to take away, I'll be very happy. So if the case, when do you ask for a topography to rule out a keratoconus? So these are the only things that I want you to take back. The case, if you find a more than 46 diopters by automated refractometry or keratometry in any of the eyes, ask for a topography. If you find the cylinders are more than 2 diopters, then ask for a topography. If asymmetrical cylinders, let's say the difference between the two eyes is more than 1.5 diopters, suspect keratoconus. Again, if there is a progression of the cylindrical number on regular follow-up, it keeps going up, and you're not like, getting 6/6 vision even with maximum cylindrical correction, do not blame it as amblyopia, look for keratoconus. So if the vision is not improving to 6/6 with full cylindrical correction, please suspect keratoconus. Again, slit lamp findings of KC usually occur much later, so if it is there and we can pick it up, fine, ask for a topography. And the most important, retinoscopy showing scissoring. So that's something that you have to learn, and you have to keep looking at patients to know what is a scissoring reflex. So if it shows a scissoring, then please ask for a topography. So these are the indications for topography to rule out a keratoconus. Now the last bit where I wanted to talk about contact lens fitting. Now this is very important from an optometrist point of view. There are few maps which are very important in contact lens fitting. The axial map is the most used map, and this is used to determine the base curve of soft and GP lenses, scleral lenses, because we have very detailed central curvature data available, not just 1 or 2 values like the keratometry. You can also look at the elevation map, but the elevation maps are usually used only for regular corneas. So we'll know what is the starting GP that we can place on the eye. We don't have to go by trial and error. So in toric corneas also, we can know whether we have to give only a spherical lens or should we give a toric lens for this patient. So that we can know. The general thumb of the rule is that if the steepest elevation compared with the flattest elevation shows a difference of more than 300 microns, none of the lenses will work. Only a scleral lens will work in such a condition. So it is important to remember that rule before we go for fitting a lens. The tangential curvature map, these are very critical in understanding the true shape of the cornea. So as I told you earlier, it gives the true size of the cone in the center. And these are also important for fitting ortho-K lenses. Now these ortho-K lenses are used in the treatment of myopia. So in children especially, so these lenses can be used as overnight lenses. Children wear them in the night and sleep, and morning they are free from their glasses for a day. So again in the night they use the lenses. So these kind of ortho-K lenses have been in practice for a long time. They are coming back now and they are being widely used. And this is especially useful for children who are into active sports, who are in swimming, who are in football, or going for such active activities, and they cannot wear glasses or even manage contact lenses. So for these ortho-K lenses, you need to have a good peripheral fitting. So that is where these scans come in. And a few other things like determining the apex of the cornea, especially when you're planning multifocal lenses. So multifocal lenses, you need to know where the center of the cornea is. So even nowadays, even GP lenses and scleral lenses come with multifocality. For presbyopes, you can give multifocal lenses. So modern topographers have GP fitting softwares. So what you can do is, they'll allow the practitioner to select a lens and it will simulate the fluorescein pattern. And you can adjust the parameters. So you don't have to worry about what your starting lens is going to be. You don't have to keep putting it on and taking it out. You'll know how the fluorescein pattern itself is, and the topographer will tell you how it is, and you can adjust the lens accordingly. So there are two values that are important. One is the E value. The E value is the rate of flattening from the central cornea to the edge. Now, it differs in prolate corneas. Prolate corneas are corneas which are steeper in the center and flatter in the periphery. Hyperprolate corneas, like keratoconic corneas, will require GP or scleral lenses. Whereas corneas that are flatter in the center, like a post-classic cornea, and the vision is not improving for some reason, you need to fit them with lenses, you have to go for something called as reverse geometry lenses. So there are various lenses, and contact lens itself, fitting itself, is a big art, just like giving out a spectacle, and it is mostly done by optometrists all around the world. So it's contact lens practice has assumed great importance, and it's a very important field for optometrists these days. The other thing is the shape factor. The shape factor of the cornea is the extent to which its shape varies from a sphere, a normal sphere. So this again will help to choose the lens design and the extent to which the peripheral curves of the lens need flattening to maintain the corneal alignment. So when you fit keratoconic corneas, small nipple corneas, like small nipple cones, small central cones which are less than 5 millimeter in diameter will do well with smaller diameter lenses. But when you have slightly oval cones which are bigger than 5 millimeter in diameter, you will have to think of larger diameter GP lenses or reverse geometry lenses. And for conditions like pellucid marginal degeneration, where the thinning will be right up till the inferior limbus, the scleral lenses are always a better option. You can also fit post-graft corneas. Now the post-graft corneas, while fitting, we'll have to remember that the graft-host junction has to be taken into account and the lenses have to be bigger than the graft-host junction. So large diameter lenses like 10.5 to 12 mm GP lenses, or better option is to go for a scleral lens which will help in fitting these post-graft corneas. When we plan toric intraocular lenses to correct more than 0.75 diopters of pre-existing corneal astigmatism, then we have to rule out whether it's a regular astigmatism or an irregular astigmatism, because toric intraocular lenses that are designed for use are mainly for regular astigmatism. It will not help in irregular astigmatism. So you go and put a lens in a patient with a keratoconic cornea, they're going to come back with a lot of symptoms of glare, and they would probably want you to explant the lens. So the other thing is in intacs planning or intracorneal segment planning. So these intacs are small PMMA implants which are placed in the cornea, inside the corneal stroma, and these will flatten the cornea at a particular point. So this gives better clarity of vision and improved vision with contact lenses after they are done. So here you can see that in the anterior sagittal curvature map, you can see that the rings are placed and they'll tell you how much of flattening, what is the thickness of the ring to be placed. These are permanent implants which can be placed in the cornea. So these are very important. Topography is again very important for intracorneal segments planning. So to conclude, I don't know whether I've rushed through. I hope there are a few points that you have acquired from this. But reading a tomograph is an acquired skill, and the more we familiarize, the more skill we acquire. So you need to look at more maps, and that is the only way you can familiarize yourself with a topography.
It was a pleasure to have you with us, ma'am. Thank you so much for taking the time to speak at our event. Your insights and perspective were truly valuable, and we are all thoroughly engaged by your presentation. Once again, a heartfelt thanks to you, ma'am.
May I now request Mrs. Sonu, Organizing Chairperson, MICON-23 and Head of Department of Optometry, to hand over the token of gratitude. Now, we shall have a small photo session